Hello everyone. Welcome to 2 Minutes in Medicine. This is Dr. Anand, consultant in critical care medicine from Bengaluru. Today's topic is hypercalcemia in the ICU. Hypercalcemia poses unique challenges with respect to the diagnosis and management in the ICU. It basically represents underlying disease process, particularly malignancies, hematological malignancies, solid tumors, primary hyperparathyroidism, drug-induced, particularly thiazide diuretics or lithium. And one important, very less commonly found is immobilization hypercalcemia. Even though it is less common, but you should have a very high index of suspicion, especially in elderly patients who have been immobilized for a very long period of time, have a strong suspicion for immobilization hypercalcemia. What are the symptoms does it come with? Predominantly neurological, delirium, encephalopathy, seizures or coma, nephrocalcinosis, nephrogenic diabetes insipidus, renal failure, abdominal pain, and particularly pancreatitis is very important. From the cardiac perspective, it causes a short BR, short QT interval, and the ECG sometimes simulates Brugada syndrome, posing the patient for a very high risk of fatal arrhythmias. Coming to the physiology of calcium, ionized calcium is the most active form and that is responsible for the all actions. Total calcium is important as long as other things are stable. 45% of the total calcium is in the form of ionized calcium. 45% is bound to albumin in a pH-dependent manner. Whenever we have alkalosis, more and more calcium is bound so that the ionized calcium will be less, causing hypocalcemia, and vice versa happens in acidosis. 10% is bound to other anions. Coming to the management of hypercalcemia, as it causes significant volume depletion because of nephrogenic diabetes insipidus, volume repletion is most important. We should not use diuretics, particularly loop diuretics, until unless adequate volume resuscitation has been done. Otherwise, it causes significant intravascular dehydration, promoting again hypercalcemic crisis. Use the diuretic only if there is a volume overload. For refractory hypercalcemia, we should use dialysis, and in particularly malignancy-associated hypercalcemia, denosumab 120 mg is the right medication. Zoledronic acid at a dose of 4 mg, and we should be careful when you are giving this in renal failure patients. Calcitonin acts quite quickly, and we can use as 4 to 8 unit angiotensin per kg in divided 6 to 12 hours doses. Cinacalcinate particularly useful for primary hyperparathyroidism, which is severe, or specific to parathyroid carcinoma, we should use cinacalcinate. And in hypercalcemia related to sarcoidosis or lymphoma, glucocorticoids act wonderfully in reducing the calcium. So have a high index of suspicion of hypercalcemia whenever dealing with such patients. Thank you very much.